And I think we'll go ahead and get started here. I am very pleased to have everyone on the line and to be inviting Janelle. Janelle Shearer is one of our colleagues at Stratus Health, and she is going to be leading today's session. And just an FYI, Kim is on a much-deserved vacation to see her fully vaccinated parents in Ohio. So she is not with us today. But I think we'll have some really great discussion led by Janelle, and hopefully a couple more people hop on the line here. And with that, I think we'll just get started. So Janelle, if you want to go to the next slide, we do this every time, but I wanted to do just the quick check-in call to share your name, your role, your organization location, and our really fun question today, which is, you'll see how this is related to our topic in a little while. But our check-in question today is that the zombie apocalypse is coming, and who are the 3 people you want on your team and why? And so with that, I think I will just go first. Again, my name is Carrie Howard. I am a program manager at Stratus Health and largely support our partnership to advance tribal health program and a couple of other rural health programs, including this Flex Population Health project. And I work for Stratus Health, which is based out of Bloomington in the Twin Cities area, but I actually live in Bemidji, Minnesota. And for my zombie apocalypse team, I choose my husband because he is very tech savvy, where I am not, and I just like to be around him. My cousin Casey, who is a massive 6'5" lumberjack, wilderness, jack of all trades kind of guy, pretty tough and knowledgeable. So I feel like those would be good skills to have during the zombie apocalypse. And then my third person, I kind of went back and forth, but I think I choose my friend Rachel Peterson, who is a pretty tough lady herself and a marathon runner. And my reason for that is because I feel like we could use her at any time as a diversion, so she could just outrun the zombies as they're coming. And then again, like stamina wise, outlast them, so she could just run her loop and come back and get them to follow her. And I don't mean to use her as bait, but I feel like her skills would be really helpful in the case of a zombie apocalypse. So with that, I'm going to then hand it off to Janelle to introduce herself, and we'll hear who's on her zombie apocalypse team.
Okay, so I'm glad you went first, Carrie, because I had to be thinking about that for a little bit. So I'm Janelle Shearer. I am a program manager at Stratus Health, which is our office is in Bloomington, but we've been remote for a year now. So I live out in Prior Lake, or outside of Prior Lake on the south side of the Twin Cities. And my 3 people, I picked my husband too, because he can calm me down, I guess, or he sees things more rationally, kind of like during COVID. I feel like this is kind of a semi what we've gone through this past year. And then now I have 3 daughters, and this is terrible, but I picked 2 of them so I picked my oldest one, who lives nearby me, because she's very strong emotionally and physically and very practical. She'd be the one to say, pull the plug. And then I picked my youngest daughter, who doesn't live here, but she's the caring one. She's the one who said, hey, Mom, if you get dementia, I'll take care of you. So if something bad happened with this apocalypse, she would be there to be caring.
That's awesome. Thank you, Janelle. And we won't tell your third daughter.
She's in Switzerland, so, she's kind of far away.
She'd be on somebody else's team. Yeah. It looks like Ellie chatted in because I think you have some audio issues in actually us being able to hear you. But Ellie from Cass Lake, the acting quality manager in Cass Lake, says that she would take her husband because he knows how to handle any situation, and then her kids because they're very athletic and can motivate me to accomplish anything. So thank you, Ellie, for sharing that in the chat. I think we will then, I'm just going to go down my list according to who's popping up in my participant list. So the next person is Ashley.
Hi, can you hear me?
I can.
All right, perfect. I could not find which screen I was on. So I am from Sanford Wheaton. I think in a zombie apocalypse, I would probably take my husband because he can hunt and do those things. I would probably take my sister-in-law because she can and also hunt and do those things. So in case we were crowded up. And then I'm going to need a nurse. So I'd probably take Chelsea because she could then help me if I'm hurt.
Yeah, good choices. Good choices. And actually next on my list is Sherry. So I'm wondering if you're also going to take Chelsea. Sherry, you are still on mute if you are trying to talk right now.
I'm sorry. Were you talking to me? This is Sherry.
Yes, yes.
I had somebody in my doorway talking.
Oh, sorry. Yeah. Sorry about that.
All right. So I'm Sherry Rickamoto, and I am the clinic supervisor and the RN care manager at the Wheaton Sanford Clinic in Wheaton, Minnesota. 3 people I want on my team. I would probably pick all 3 of my kids. My husband would be very good, but they would be better telling him what to do than him telling them. So I'd probably pick, I've got 2 daughters and a son. My oldest daughter is an RN, healthcare administration, master's in that. So she's used to handling all kinds of problems. My other daughter is a kindergarten teacher, so she knows what chaos can be like and things. And my son's an electrician and very particular in everything he does.
Yeah. These are great skills to have on your team.
So that's who I'd pick.
All right. Yeah. Thank you, Sherry. Next, I have Greg.
Good morning, everybody. This is Greg, CEO of Lakeview Hospital in 2 Harbors. This is the toughest question I've had all day. I would say, number 1, I would pick my wife because she's the voice of reason in our family and could sort through all of that. The second person would be our admin assistant at the hospital because we probably need a hospital to care for people, and she would keep it running as I was maybe running or doing other activities. And then the third person would be my oldest son because he is physically fit, smart, and a good problem solver. So I think the 3 of us could maybe survive for a few days.
Yeah, great. Great. I like this mix of people picking coworkers and family members because the skill set that everybody different brings to the table is super helpful. The next person on my list is Joanna. And Joanna, you might have to push *6 to unmute yourself on the phone.
Can you hear me now?
I can.
Excellent. My name is Joanna Ferrara. I'm the acting clinical director at Cass Lake Indian Health Service. And this was a really hard question because I'd want to bring a lot of people. But the top 3 that float to the top of my list is a coworker, physician assistant, Dan, who is would be good in a medical emergency, or he hunts as well. So I think that would be a good resource to have. I'd also like to bring my cousin Steve, because Steve is, he gets along with a lot of people, and I'm hoping that maybe he could befriend a zombie or two before they hurt us. And he's pretty funny, so I think he would bring a sense of humor and maybe a little de-stress to the situation. And finally, I'd probably bring my friend Amy. She's an RN, and she's pretty resourceful. So I think between the four of us, we could probably handle most of the situations pretty well.
Yeah, I like it. I like it. All right, next we have Christy. And Christy, you too, you might have to push *6 to unmute your line.
Now can you hear me?
I can.
Okay. This is Christy Inger. I am the lead RN care coordinator here at Olivia Hospital and Clinic. This is a difficult question. I guess I would pick my husband first. He's good at hunting and all sorts of different ways of hunting, so that would be helpful. And then I would probably pick both of my sisters. We all were trained to be very self-sufficient, so cooking, canning, gardening, hunting, changing tires, running equipment. So I would think that we would do a pretty good job.
Awesome. Thanks, Christy. The last person, I'm not sure who it is that is joining us. They are titled on my Zoom list as Telehealth SCBHS.
Hi, this is Holly from Benson. Can you hear me?
I can. Hi, Holly.
Yeah, I just grabbed one of the iPads here instead, so it came up as that. Sorry. Holly from Benson. I'm one of the registered nurses here at the Benson Hospital Clinic area. For the zombie apocalypse, I would probably bring my husband. He is actually an auctioneer, and he could probably just talk his way out of it. My sister-in-law, she is very resourceful. What's the problem? Let's get it done. And then the radiology manager here as well. Same, what's the problem? Let's get it done. And we would figure it out.
Awesome. Thank you. And thanks, everybody. I know that was a tough question. I had been thinking about this. You know, I had the advantage of thinking about it for a little more time. And it was even hard for me. Like I think it was Joanna that said, I want to take a bunch of people. I don't want to just take 3. It's hard to think through that. It looks like 2, we had one more person join. It looks like Rachel just joined. And I know you're coming in on the tail end of this, but Rachel, our check-in question today is, who would you bring on your... There we go. Thanks, Janelle. The zombie apocalypse is coming, and who are the 3 people you want on your team and why? So if you want to unmute and just share quickly.
I'm sorry, I'm going to have to pass on that. I have 2 things going on real quick I have to attend to.
Okay.
Sorry.
Yeah, no problem. No problem. We'll just keep moving on. All right. So with that, Janelle, I think the next slide is your, oh, that's right, debrief. Let's debrief the last session. So for those of you that were able to participate live, the last session we focused on the one-to-ones. So our first session, we were talking about creating our motivating vision and our story of self, our story of us, and the story of now. Our second session then was about one-to-ones and how to structure those intentionally to learn about others, learn about what skill sets and interests that they have. And one of your assignments, I guess, from the last session was to try to facilitate at least one-to-one with someone. And so I just wanted to check in with the group and see if anybody had time to practice that. And if so, if you would be willing to share a little bit about your experience or your reflection on the content from our last month's session. So just go ahead and unmute and jump in. I'm going to mute myself for a little bit here. Feel free also to add into chat if there's anything that you wanted to type in versus speaking up verbally. But even if you didn't get a chance to facilitate a one-to-one, any thoughts or reflection on last month's session about the structure of a one-to-one, the structure of an intentional one-to-one?
No, I guess this is Greg. I can share my example from Lakeview. And I know Rachel probably has one, but we're running another community COVID vaccine clinic today. So she's coordinating all of that. So she's going to be back and forth because we've got a couple hundred people coming. But I engaged in one of these relationships with somebody that I knew fairly well. It's our Lake County Sheriff. But I really practiced the techniques that were shared last month around a discussion about really contracting or partnering for medical direction of our rescue squad. And I knew, and I think where it was helpful is I know him fairly well, but he had a previous arrangement where they weren't paying for a service, and we were proposing to do a new partnership where they covered the cost. So I think the dynamics were a little bit different, and it actually worked well. It was kind of fun to look back on what we practiced and use it with him. And that discussion went really well. We were able to come to an agreement. We've got a contract now for another community service that's outside of the walls of Lakeview, that's more kind of population health focused, and just really supportive of our community. So it was good.
That's awesome. And I also really appreciate the thought of, it doesn't have to be a stranger. This is somebody you already knew and had, at least some kind of working relationship with, and using that structure kind of changed the conversation. Really great example. Thank you for sharing, Greg. Anyone else want to share anything about practicing one-to-ones or thinking about the structure of a one-to-one?
This is Holly from Benson. I did do a one-to-one meeting. I caught somebody in the hallway, set up a meeting time where they actually had time to chat. And then we did discuss things, kind of briefly on what we could do for some changes with the population health. And then once we did that, we actually decided to both go kind of just think on our own again. And then we're actually going to get back together and talk about it again. So we're going to revisit the whole conversation.
Great. And I really like the specific next steps. We want some more time to think about this. So let's come back and talk about this some more. I really like that. Thank you, Holly, for sharing.
Yes.
All right. I think with that, then, you guys did a really good job. Thank you for doing your homework and for starting some of those conversations. Again, these are skills that we will promote and practice throughout the rest of this LOA content, but then also throughout the rest of the project. So, this first 6 months, we're focusing on the leading and organizing in action, or the LOA content. And then we're going to be moving into actually forming and facilitating, a population health focused community coalition, in whatever manner that means to you and your facility and community. But those one-to-ones really are going to be key throughout that whole process. So it's not something you just do in the beginning and then it's done. You're going to be, as we go through, and learn more, you're going to learn that these kind of pop up again and again and again as you're looking for additional leaders or additional partners or or whatever that might be within your community. All right. So with that, I think now is when we're going to hand it over to Janelle. And I think we got a brief bio slide to introduce. You can introduce yourself, Janelle, and then I will let you take it from there.
All right. Yeah, when I put that picture on, I thought I had it fairly small, but I have a big screen computer, so it's bigger than I like. So thanks for having me to your session this week. I'm Janelle, and I have been at Stratus Health 17 years. Prior to that, so I'm an RN by background, and I've spent most of my clinical time working in a rural hospital in Southwest Minnesota. So the town is called Fairmont. It was Fairmont Community Hospital when I was there. And so did a lot of things. It wasn't critical access, but I think they were licensed for 76 beds and then dropped down to 70 or 44. So probably like many of you or the clinicians at your hospitals have done a lot of things, worked, their med surg, their ICU, CCU, OB, was the evening supervisor for quite a few years. And then I started the home care and hospice program and directed that for 10 years before we end up moving to the metro area. And I've been at Stratus Health since. At Stratus Health, I tend to work on projects that are related to rural end of life. So I've done a lot with palliative care, community-based palliative care in rural communities, care transitions, readmissions, those types of initiatives. I've been through this LOA training a couple of times. So when it was first introduced to the quality improvement organizations, way back, probably, 8 years ago, I'll just say. And then again, a few years ago, I went through another training. So I'll be honest, I use these techniques in our work, and a lot of them we had used before, but this put it into a program. And so it just really made it more kind of structured. And so when you think about the one-to-one meetings, I think the thing that I learned most from those is getting that commitment, at the end. It's fine to meet with people, but then I was just kind of nervous about getting a commitment. And so I would practice that. I mean, you can practice these skills on like friends, because a commitment could be, let's meet again, share that recipe with me. But then when we are related to our work, the commitment is a little bit different. But it was fun to go through the skills in my head and actually get commitments, and people mostly said yes. So today we're going to talk about just the importance of relationships and why we form them and have them to help us in our work. We're going to learn about the mapping the actors and how you can recruit and implement to have more resources for your team. And then we'll actually have you guys practice how you're going to identify and recruit leaders that you want for your coalition. Okay, so I was busy looking at the chat. Thank you. So now we're looking at adding power to the equation. So you've seen this equation before. So we're adding how we can get the right people to bring us the power that we need to make the change. So the thing that we want to work on and improve. And it's through the commitment that we have with people that we build this power to make the change. And so there's lots of reasons that we have relationships, right? So when we're thinking of our work and the things we want to make a change, it's to help us get things done, because we can't do it alone. We need help. We don't have capacity. And by having other people work alongside us or with us, we have capacity, which gives us the power to make the change. And so we distribute the work of the efforts we want to do by forming a leadership team and having the capacity to actually get something done. And our meeting with people in the one-to-one part, where the recruitment is very intentional. So we're not just haphazardly getting folks or organizations to work with us, but it's very intentional and thoughtful. And that's what we're going to be working on today. So this is called the Actors Map. And it shows the different types of, I guess, buckets that actors will be in when we're working on a coalition. So I'll talk about some of these. And so, like I said, it's very intentional who we're going to approach to work alongside with us. And we may know who some of them are, but as we meet with people many times, that list will grow and it might change and evolve. So it's kind of an evolving map, I'll call it. So you'll be doing an analysis of thinking about individuals and organizations, what their interests are, what their resources are, what you need, and what they need, and then you'll be mapping it out. So we'll talk about the most important one first, and that's the constituency. These are the people or organizations that are going to be working with you on your initiative. So you have the same shared values. You will be partners together. So they aren't your customer, they're not your client, but they're partners. And out of the constituency, you'll have leadership. You'll have a leadership team that will actually help guide the work. The next group are the supporters. So these, again, are individuals and organizations. They share your values, but they're not going to be into the weeds and actually do the work with you, but they would support it. So in this bucket, I would think of organizations, and I'll give you an example in a little bit, but maybe like trade organizations or a philanthropy organization where they support the work, but they're not actually right in there with you doing it. Competition are those people or organizations that, again, they share your values, they share what you want to do, but they are going about it differently. They maybe have a different approach. Also, they might be competing with you for the same resources. So you want to try to get your competition, if you can, to be supportive of you on the support bucket, or maybe even in your coalition, be a part of one of your constituencies. And then on the bottom of the diagram here is the opposition. So these are the individuals or organizations who they would lose something if you succeeded. And so think about, what is it that somebody could lose if we succeed in what we want to do? If you meet with folks and they're resistant, try to figure out why, like what's going on with their organization, or what are we working against? So one example here might be, say you're working on something in healthcare and an opposing, somebody in the opposing bucket, they might lose, say, revenue, especially when you think of like in the PPS payment system, where if you have less, say, readmissions, for example, you have fewer readmissions, you're paid less, right? So why would you want to have less readmissions when you look at it from a financial point of view? So that would be one example of opposition. So again, the most important group, and the one I really want you to focus on today, is your constituency. So who are going to be your people who will work alongside you? And I wanted to say, feel free to jump in, ask a question, make a comment. I'm totally fine with being more relaxed and doing this.
Yeah, Janelle, I think to your point and us thinking about or focusing on the constituency, I think hopefully it is clear now why we started with that check-in question, because we're talking about who do we want on our team, with the silly example of the zombie apocalypse. But this is really the meat and potatoes of our community coalitions, right? It's the who are going to be the key players with the skills we need for this to succeed.
Mm-hmm. And Carrie, I thought it was brilliant, your intro question, because it so fits in. It's because you're thinking, what are the skills that, I want with me? And it's the same thing. What are the resources? What are the interests of the people that I want to be with me and work with me in this coalition? Okay, so then you have to click on there we go. So the other thing you want to map is, or think about, would be the assets that you need. So we put those in a couple of buckets. One is the natural resources. So these are things kind of like we're born with. You know, we have time, we have energy, we have ideas, we have interests, those kind of things. And then there are acquired resources, such as money, skills, knowledge. It might be technology. It might be you have some organization has a meeting room. You need that. Or it might be a Zoom license, or it could be all kinds of things, but more acquired resources. So you want to think about what are the resources we need, what do I have, and where are the gaps? So where do we need to find those from other organizations or other people? So a resource is really anything that we can use to achieve something else. So things you touch, or it could be influence. It could be, having motivation. There's just all kinds of different resources that could be counted here. So when we think about mapping our power, power is the influence created by the relationships between the interests and the resources. And a coalition's power is to create change. It comes from the people. So that's why we're recruiting people. And so the 4 questions to ask are, what are our interests? What do we want to accomplish? What do we want to do? Who holds the resources that we need to address those interests? And then when you're meeting with other people or organizations, you're asking, what are their interests? Okay, what are they interested in? And what resources do we have that we can commit to meeting their interests? So you want to be mutual in your exchange in resources. As you know, as you're asking someone or an organization to participate in your coalition, it's not like we just only want stuff from you, but they need to be able to get something out of it as well. So those are the 4 questions to ask when we're trying to map out our power to see who do we want to invite to be a part of our coalition. So we love Post-it notes, right? And weren't they invented by 3M in Minnesota? I'm pretty sure 3M invented it. I don't know for sure it was Minnesota, but that's where we're based. So we use Post-it notes to figure out who our actors will be, mapping our actors. And so what you want on your note is an organization or key contact. And you see, here's an example. The one on the left starts with an organization. The one on the right starts with a key contact, and then the org is underneath. List the resources that they have, list the interests. So I'll just kind of review the one on the left. So Stratus Health, where Carrie and I work at, our resources, and this is pretty high level, but we have resources in healthcare quality and safety expertise. We have a wide network in Minnesota and across the nation, have a great reputation. Organizations know us, they recognize us. We have improvement and implementation experience. We also have, when I think about a coalition, one thing that's been a real benefit, we are a neutral convener. So it's not like we play favorites with organizations. We can bring competition together pretty easily. We also have a lot of folks that are good at facilitating, so can facilitate meetings. We also have resources of say, grants and funding to help organizations do initiatives. And then our main interests are healthcare, equality and safety, equity, and rural health are some of our main interests. And so you can use this model for things in your work life, what you're doing in this initiative. You can also use a lot of this in your own personal life, things that you're interested in as well. So I see on Kim here that she's interested in music and that kind of stuff. So if you're doing something in your personal life related to that, Kim might be somebody that you'd want to recruit. So I have an example here of an actual map that I did for an initiative, and I thought I would share it with you and just kind of explain it. And I don't know if you can see the words very clearly because it looks pretty small depending on how big your screen is, but I'll just review it with you. So, and I actually, it was a project I did a couple of years ago when I was working on preventing readmissions across the whole continuum of care. And Minnesota at the time had a pretty good readmission rate. I mean, we were better than the national average, which was causing us struggle to get improvement because we were already so good. So I asked our analyst on the team, Laura, if she would do an analysis to see if she can find a gap somewhere in our services that we could work on here in Minnesota. And so she did analysis. We have access to claims data. So she looked at claims data and she looked at patients that were in the hospital and then referred to home health post-discharge. And so you can get that off of claims. Then she looked at claims data from home health to see how many of those people that were referred to home health received it. And what she found was a big gap. She compared the data nationally, and in Minnesota, for some reason or another, we were much lower than the national average on when you were referred to home health post-discharge to actually receiving it, to have a claim that showed you received it. Then she went one step further and looked at readmission data and discovered another big gap. And that was if you were referred to home health and did not get it, you had a much higher 30-day readmission rate. So we wanted to figure out the problem and focus on something that we could do about it. And so we started working on this, what we ended up calling was a home health gap collaborative. And actually at this time, I was going through the LOA training for my second time. And so I was really trying to practice the skills as we started this collaborative. So it worked really well. So first off, you think, okay, who cares about this? So, in our minds, it's like, who cares the most about this? We thought, well, probably home care, because they're not getting the referrals or they're getting the referrals, but people aren't receiving their services. So I did a presentation with a small group at the Minnesota Home Care Association. They have a clinical quality team that focuses on quality improvement. So it's mostly home health agency directors from around the state, and met with them. And we talked about the initiative, showed them the data. They were really interested, trying to brainstorm, figure out some of the reasons. And then we talked about forming a coalition. And they said, who else really cares about this? Hospitals. We need to have the hospital association on this. So I ended up doing a one-to-one with some folks from the hospital association, and they were very interested in doing this, working on this coalition with us. So we ended up forming a leadership team, which was Stratus Health, the Hospital Association, and the Minnesota Home Care Association. So we were the leaders of this coalition. Also, the clinical quality team and the leadership team, we thought, well, who else cares about this? And that's a question to keep asking other people, because, if I would have done this alone, it probably would have been Stratus Health and home health agencies. But by meeting with other groups and people, they had better ideas and great ideas. They said, well, skilled nursing facilities, they care about this. They refer to home health after people are especially there for a short-term stay, and they're getting penalized if there are too many, if the 30-day readmissions are above a certain level. So they said, let's invite them. Let's also invite other community partners like public health, area agencies on aging. How about the payers? They seem to care about this. And then we also invited, let's hear from a patient and family. So we recruited patient and family. So this diagram is kind of a picture of after the recruitment was over, but I just want to share with you who was in our constituency. So on these sticky notes, I have the organization, actual people, contacts. I have what their interests are, and then what resources they could bring to the table. So we had home health agencies. So their interests are, they want to increase their referrals, right? They want to increase the home health uptake is what we called it. They also want decreased readmissions. What they bring to the table are best practices. best practices on how to get people to receive home health, how to inform people about home health. They also have time. For the QIO staff, okay, so that was me. We had staff, so I had a grant that was paying my time and time for Laura to do the data analysis. We had data too. So we had data for all the organizations in the state, and we could look at comparison data with the nation. We had relationships with home health, with actually all across the continuum. We had facilitation expertise. And so that's what the QIO brought to the table. The other organizations, so the Minnesota Hospital Association, their interests were to help hospitals reduce readmissions because hospitals are penalized by too many readmissions. They also had staff time. They had grants that were paying them to help with this initiative, and they had good facilitation skills. The clinical quality team at the Minnesota Home Care Association, they had leaders in home health. So those folks had influence, they had best practice, they cared about readmissions, and they really cared about having referrals, people accepting their services when referrals were given. Let's see, who else did we recruit then? So we recruited hospitals, and they had influence. When you think of kind of the hierarchy, I guess, or the structure with healthcare organizations, hospitals seem to be at the top, right? So they had influence. They also had their own data. They had best practices that they could share. We had some critical access hospital health systems be a part of it, particularly one that had a wellness coordinator who worked across the continuum. So this person worked in healthcare home and outpatient, and she was an influencer. She also had best practices. The skilled nursing facilities, we recruited them because they cared about readmissions and they refer to home health. They would have skilled nursing facility best practices. Let's see, what else did I have? The Area Agency on Aging. We wanted them and they recruited them and they participated because they have the community outreach. So they reach consumers out and about in just the normal community. We did also recruit a patient advocate. It was a daughter of a patient in one of our other coalitions. And I will just tell you that her comments and input was invaluable because she truly saw it from the patient or consumer's point of view, and we changed things because of the input of that person. So those would be our main constituents. This was a virtual collaborative because we wanted to be statewide. So we met by Zoom virtually. We ended up doing like a root cause analysis over Zoom. We prioritized the areas, we split into subgroups, and then we ended up where I led one subgroup with somebody from the Home Care Association, and then the Hospital Association led a subgroup with somebody else. So we had two subgroups, and the model really worked beautifully. So our supporters in this case, we identified trade organizations. So the hospital, the long-term care, and the home health trade organizations. And what they brought to the table was they had an interest in the topic. They wanted to support their organizations, in the members of their organizations. What they could do for us or what resources they could bring, they supported the initiative, they promoted our recruitment, and it was a venue for us to share our lessons learned when we figured out what our issue was and what we could do about it. Our opposition, we couldn't really think of organizations, but what we felt were opposing things to this was time, because there were so many competing priorities, finances, which also converts into time. So those were the main things we thought of as opposition. For competition, I put down privately owned home health agencies, because many times I've noticed in working with home health, there seems to be this competition between like the hospital-based agencies and the private-based agencies, and I hear them kind of complaining against each other, especially the privates against the hospital-based. They think that they're not sharing about their organizations for referrals, basically. And then I put ACOs on there as well, where that could be a competing or a competition just because of the different approach that they may take. So I'm going to stop and just open it up for questions here before we go into our practice time. Does anybody have any thoughts or questions or just comments, I guess?
This is Carrie. I am hoping that this process and this tool looks familiar to the Cass Lake IHS facility, because in a couple years ago, in our first go round of our partnership to advance tribal health work, we actually did walk through this activity with that group as we were working on the community health needs assessment. And so I'm hoping that Joanna and Ellie kind of recognize this and that you can remember kind of what that process was. The one thing that I wanted to note about that process is that you might find that, you know, a certain organization or even an individual might fall into a couple of these different circles. So they might both be a supporter and a competitor, or, you know, in competition with that. They might be in both the constituency and within the supporter role or something. So sometimes you kind of run into that as you think about, especially when you're talking about an organization. And that's okay. You just write out another Post-it and put it into that circle too.
Yeah, good. That's a good point. There could be like two different people, and one could be like a constituent, and another could be, you know, in the opposition bucket. On my diagram, I didn't pull out or make a separate little bubble for the leadership team, but I just want to maybe repeat again that the leadership team comes from your constituency. And so in this case, it was Stratus Health, the Hospital Association, and then this clinical quality team there too. Another thing is this diagram, or as you're recruiting, it evolves. So I remember recruiting for another initiative. We were forming coalitions where we were bringing healthcare organizations across the continuum together to work on readmissions. Actually, it was this home health gap was in that coalition. So I was trying to recruit one of the large health systems in the Twin Cities. And so, you know, we brought the data, we talked about mutual things. So it was a one-on-one meeting, basically, what they were working on, what they were interested, shared what we were working on. And in my mind, you know, I was thinking, I need to have something to make them want to do this with me. What can I offer them? So we think of the resources. So as we were talking, they shared with me that they bring together the nursing homes, skilled nursing facilities that this hospital refers to. So they had this whole process where they selected organizations had to basically apply to be in their preferred group. And then they had asked them questions related to, I gotta think about this because it's related to an evidence-based program, like how they communicate, how their readmissions rates were, transfer forms, and that kind of thing. And so as we were talking about it, it's like, well, how do you know? I asked, how do you know that they are implementing these things, or they're doing what you say, or they've had the trainings for what they said on their application? And they said they really didn't know. So we had been trained in this evidence-based program called Interact, which is for basically skilled nursing facilities as they transfer to hospitals or other organizations. And so I offered to provide training and data for the skilled nursing facilities in their group. So when you talk about resources, it wasn't just me wanting this large health system to be a part of our coalition because they had influence, for one thing. They had resources, but I wanted to bring something to them. So it's mutual. So mutual sharing of resources together. And we were able to do that. They joined our initiative. I provided education, kind of ongoing education to their group of skilled nursing facilities. So it does evolve over time. And it's kind of fun as you kind of draw out your plan, and then you have your one-on-ones. You may find things that you didn't know. So maybe they end up in a different bucket or they have different resources. A good question to always ask is, who else would care about this, or who else should we reach out to? Because the people that you meet in your one-to-one, especially, you want to meet organizations and people that are different than you. If you have always, if it's always the ones you know and work with, it's kind of going to be the same, but you want different points of view who have different contexts, so your reach is bigger. And I'll just share one more thing I learned during this time. It was when I was kind of strapped with hours and resources, and I was going to be leading this subgroup by myself. And Kim actually was the one that encouraged me to reach out to one of the home health agency leaders and just ask if she'd be willing to be a co-lead with me. And so, sometimes it's hard to ask healthcare organizations to do things because we know they're so busy, but I did. And she accepted, and we had this, it was just like a fantastic working relationship leading this subgroup for the coalition. And I feel like we just got much farther than if I would have been doing it alone. So that was a good lesson for me. Just do the ask, and all they can do is say no. But it was real positive for us. Okay, I'm going to go to the next slide here. So now we're going to do the practice of the mapping actors. So you can do this either in the guidebook that Carrie had given you, and it's on page 23 and 24 if you have that handy and want to pull it out. So 23 shows the pictures of the resources if you want to just kind of jot down some of the resources that you might need. And then page 24 is that actual bubble diagram. Or you can use Post-it notes or sticky notes or scrap paper to figure out these things. So as you're mapping your actors, let's start with the contingency and think about who are those that really care about this. As you think about what are their interests, like what do they care about? What resources do they have that we might need or might want for our coalition? And do you have a name that like a main contact? Or say you don't, do you know someone that could introduce you? So start with that. If you think of supporting organizations or opposition or the competition, go ahead and jot them down, but really focus on the constituency here. So I think what we'll do is, it sounds like we had a few people from the same organization, and I don't know if you guys are in the same room and you can work together, that would be ideal. But if not, just independently start working on writing out your map of actors for the constituency. Okay, so let's just kind of debrief on this or see what it felt like. So just kind of what went well, what was hard. Did you have anything new that developed, either a new plan or action that was developed? And then I'd like maybe one or two just to share a little bit about some of the constituents that you identified for your group.
This is Ashley and Wheaton, and I can go first, I guess. Our project is to kind of go through the depression and mental health making sure depression scores are lower and focusing on mental health within our community. So our constituencies were going to be Chelsea Falk, who is the senior director here at Sanford Wheaton, myself, Sherry Rikamoto, who's the clinic manager, also on this team with us, the Sanford Wheaton Medical Center nurses and providers, both on the clinic and the hospital side, since we're critical access and small. And then Heather Mueller, who just kind of ties everything together and helps us keep staying on track. Our leadership would be Sherry, Ashley, myself, and then Chelsea as well. Our supporters was going to be public health and social services, the schools, the police departments, different things like that throughout the community. And I don't have any competition or oppositions. Those are my hardest parts to try and find. Hopefully no one is opposed to us helping our mental health and depression in our community, and our competition, hopefully we all will work together in our community and won't have any issues with that as well.
Thanks, Ashley. So I have a question, and I'm new to this, so maybe everybody else knows. This initiative that you want to start, is it just the hospital doing it, or are you bringing in other folks from the community that will be a part of helping you?
We're going to work together with public health and social services. Our goal is to hopefully get some counseling sessions in the schools, different things like that, but also lowering those depression scores in our hospital itself. So.
Okay, great. Yeah. So how was it? Was it pretty easy to figure out, or was it challenging?
Well, I thought our group and the supporters or the allies were easy, but like I said, the competition and the opposition are hard to decide who those would be.
Mm-hmm.
Yeah, Ashley, I think that's a good point too, that hopefully the pool of people that are in those two categories is pretty small, especially in a small rural community. And I think you're exactly right. Those tend to be the harder ones to figure out or to be thinking about in that framework. It's a little easier to think who should be on board and who do we want to be on board than trying to think from that other perspective of what arguments might there be against this, or who might, have strong feelings the other way about this. That is a little bit harder for us to wrap our brains around.
Yeah. Did you think of anybody new today that you hadn't thought of before?
No, not really.
No. Okay. Great. Thank you for sharing. Somebody else?
This is Rachel from Lakeview. I can share.
Thanks, Rachel.
We're potentially thinking of a project where we're working, our medical provider is us collaborating with the public health in Lake County to meet population health needs. So we identified our constituents as the Lake County Public Health staff, human services, and some of our lead employees, in addition to the county board. Leadership is identified as Lakeview's leadership team. We have supporters in wilderness health, community partners, and other local nonprofits. These are just groups that are doing similar themed missions in our community already that could combine forces with us. We expect there could be competition from a large regional provider with the similar goals. And opposition could come in the form of current Lakeview and Lake County employees, just the fact with shifting roles or combining forces change and such, as well as the potential for some patients to misunderstand the goals of the collaboration.
Yeah, great. Thank you. Do you have you considered having your leadership team be more than just your hospital or health system?
Yeah, I think I should have mentioned that, definitely.
Mm-hmm. So probably pull in the public health, some of the public health folks, would you say, exactly, as far as leadership? Yeah.
Thank you.
Yeah, I think, Janelle, I have kind of the same thought, and both with Ashley's, kind of report out and with Rachel's that, what we really want to be moving towards is, again, having fewer people in that supporters role and moving them into the constituents and or the leadership, subgroup of that constituency group. So, if we are able to identify organizations or individuals within the community that we think are going to be great supporters, then that's where we want to leverage that one-to-one conversation and say, hey, I think you actually could be on this work group, or somebody representing your organization would be really key in helping us move this forward. And so I think that's another thing too, when you start mapping this out, you're doing exactly the right thing, where we kind of identify the people we know and the people we've worked with before, whether they're, within our internal organization or, external partners we've worked with before. That usually is where that constituency starts. But then as you map those out to figure out who can you actually pull in, and they may come from the opposition or the competition category, as you start this process, and then we can pull them into being active partners in the work as well.
Mm-hmm. Another thing to consider, I know when we've recruited for different initiatives, is trying to make the leadership, trying to make a level playing field. So in healthcare, like I said earlier, it seems like hospitals are on, they're on the top of the hierarchy. Everybody kind of bows down to them, right? So when we've had the community coalitions working on readmissions and work groups, one of our requirements were that the leads, we'd ask for co-leads always, which provides a supporting structure, but then that they're from different organizations. So, and they couldn't be like two from the hospital. So many times we would have a work group being led by a hospital and a nursing home, or a nursing home and a assisted living facility. And what it does, it breaks down that playing field and makes it more even rather than that hierarchy. Because I sense this when I am with some of these groups where, like nursing homes and home health agencies, they want the hospital's referral, so they don't want to do anything against. And so then they don't feel comfortable like coming up and being lead. So sometimes if you can kind of set that up to make it more equal is helpful. And that's nothing to do with what you just shared, Rachel. That's just a little side note.
Yeah, I see in chat too, Ellie added for the community health needs assessment, I think the population-focused health work moving forward will be taking the results of that and actually making an action plan, an improvement plan for the community. But she has here listed that the constituency is, the community members, really. That's everybody. And different folks within the community and organizations within the community. And that the leadership team really is the Cass Lake Hospital executive leadership team, and then the tribal health leadership. And support is from the Bemidji area office. So that's an IHS structure. So the Bemidji area office and the IHS headquarters, and then some tribal partnerships. Competition might be the Sanford Bemidji, that hopefully they are not competition, but hopefully that they come on board as actual constituents and partners in the work. And I think, when we had gone through this activity in completing or developing the actual assessment, we also included community organizations in the constituency that included the tribal behavioral health program, included the school system, the tribal college, we invited the law enforcement, because the law enforcement program there was doing some of this kind of community health type of work as well, or at least data analysis. And so, yeah, there's lots of different partners. When you start on this path and start creating that list, you kind of keep thinking of more and more and more of potential partners. And then, like we said earlier, how we can move them out of those other bubbles into that constituency bubble to help really drive the work forward.
Yeah, that was a great example. Anybody else want to share theirs or have questions or you want to bring up to the group? How about, were you able to start a list of people that you wanted to reach out to and have one-to-ones or have meetings with? Or I'm just curious if anyone had on their list of constituents that you don't know, like you don't know somebody there. And just some thoughts on how you're going to get that connection.
Yeah, Janelle, I think that's a really good question too, that when you're filling out your Post-its, you don't need to necessarily know all of the details and the information. Maybe, in that first brainstorming session, it's just we think this business or organization might be interested in this, but I don't really know anybody there, and I don't really know what their priorities are, what they have to offer. But from what I do know, the very little I do know, they might have some interest and want to be involved in this. So it's that this is a working process that will change along the way, and that starting the process today, whatever your map looks like today, hopefully in a few weeks, months, it looks really different. And you've moved those sticky notes around and added more, and that you use it as a living tool or exercise.
Yes, and I don't think we should assume that we know other organizations' interests or resources. So when we're first starting out the sticky notes, these might be the things we think, but you want them to speak for themselves as far as, what their interests are and, what they have. So you hear it from them too. Well, should we move on to the next steps then, Carrie?
Yeah, I think so. Thanks, Janelle. Yeah, so next steps, this is kind of the homework page for our session today. And this is where we're going to ask you to continue this activity that you've started today with your teams, and to continue that, to map your actors and then their resources and assets. And we didn't spend a lot of time in today's session, but within your guidebook, there's also an activity around mapping the power. So that really is connected to the 4 questions that Janelle had mentioned earlier in today's session about, basically what do they bring to the table and what can we bring to the table, so that we have a mutual exchange of resources and support, instead of a power dynamic in which one organization or person holds all of the tools and the resources and the power over another. So continue to work through that over the next month before our next session. We're going to do kind of like we did today, do a check-in to see how that activity has gone and what you've learned in that process. The other to do is to, again, continue to identify those additional leaders or individuals that you want to sit down with on a one-to-one. So we just talked a little bit about not assuming we know an organization's or an individual's resources and interests and priorities, but really spending the time to have that conversation with them and figuring out how they can best fit into the goals of your population health community coalition. And then the other thing is we are going to send out, I think it's going to come out later this week or early next week, but the video, the pre-work video for our session 4, which will be in April. I think it's April 28th. And so that will be another short video. I think it's under 10 minutes, and explaining the content for our next session. And lastly, to continue that population health assessment. So I think, originally we had assigned the first 2 sections of that. Hopefully, with your check-in with either me or Kim, we talked about that a little bit, that we want you to continue working on that assessment and to get that back to us as soon as you're able, whether it's just that next section or if you complete the whole thing. But to get that back, because we will then repeat that assessment at the end of this 18-month cycle. And hopefully we've moved the dial on a few of those concepts. And with that, I just want to pause and see if there are any questions or further reflections on the content from today or either of the previous 2 sessions. And we'll give a little bit of time for that. And then I think we will adjourn for the day after comments and questions. I don't see anybody unmuting. And I haven't seen anything come up in chat yet. So everybody must be feeling good. Quick question, Ashley and Sherry, were you able to get your access to the SharePoint addressed? I know I saw Bryce had emailed you about that.
I saw that too, and to be honest, have not tried it. I'm going to do it right after this meeting.
Okay. All right, thanks, Ashley. And again, if you have more issues with that, you have Bryce's direct email too, so he should be able to help you out with that. All right. Well, if there are no other questions or comments, thank you, Janelle, so much for joining us today and for sharing your expertise and your learning. I really enjoyed hearing about how you actually use that in your work and sharing the map that you had done for that home health gap work. Again, it's something that can be applied in many ways. It doesn't necessarily have to be, just for these community coalitions. It can also be a tool or a resource that you use with your internal teams as you're working on different projects as well. So a nice a tool to have in our toolbox. All right.
Thanks for having me, and I want to wish you all the best as you continue on in this program. Hope you're enjoying it.
Yeah, thanks, Janelle. And as always, if you have any questions or needs, feel free to email either me or Kim. Kim will be back for next month's session, and we will have another guest speaker. I think Jerry Hineker is up next. So hopefully you all are safe and well, and we will see you soon.